Good morning all, and thank you so very much for giving me the opportunity. So I will be speaking on our innovation, that is a Morya's technique of nucleus hydroexpression, and it is very endothelia friendly. So what is the importance of endothelia? In brief, it allows leakage of solutes and nutrients from the aqueous humor to the more superficial layers of the cornea, while at the same time pumping water in the opposite direction from the stroma to the aqueous. So dual function known as the pump leak hypothesis, the nutrition of the corneal epithelium, stromal keratocytes and corneal endothelia must occur via diffusion of glucose and other solutes from the aqueous humor across the corneal endothelia and keep the cornea in a dehydrated state. So it transports water from the stromal facing surface to the aqueous facing surface by an interrelated series of active and passive ion exchangers. So it's very critical to this energy driven process is the role of sodium potassium ATPase and carbonic anhydrase. So as we all know that cataract surgery is the most common ophthalmic procedure performed nowadays, and continued research, advances in surgical techniques, development and modification of instruments and newer pharmacological advancements have revolutionized cataract surgical management. And the surgery has evolved from extracapsular cataract extraction to manual SICS and phacoemulsification. And the recent innovations are flax and robotic cataract surgery. And the elective cataract surgery is associated with some endothelial cell loss, as endothelial cells cannot regenerate and cellular decline below an acceptable limit of 1000 cells per millimeter square can lead to corneal decompensation. And earlier studies have reported 16 to 67% of endothelial cell loss during phacoemulsification, and manual SICS there is loss of 4 to 17% as per various literature review. So less viscoelastic cover to the endothelia, nucleus prolapse, nucleus delivery and continued jet of irrigation and aspiration are the significant factors causing endothelial cell loss during M6. So we have developed this indigenous technique of nucleus hydroexpression. So there is a specially designed beveled up Morya's hydrocannula. So this was the first design. So as you can see, the whole length is 24 millimeter and there is beveled up, the main port is there. So it has this opening of 0.6 millimeter, and then there are two openings on the sideways on the right and left side with an opening of 0.3 millimeter. So it is there, the side opening, it acts when the fluid passes through it, so it acts to maintain the chamber. So we don't need the anterior chamber maintainer. So this is the advantage of this hydrocannula. So in this is a brief about the technique under peribulbar subtenon superiotemporal, the temporal main incision, the side port and appropriate rexes after staining with blue dye and routine hydro and delineation and nucleus prolapse into the AC. Then this specially designed beveled up hydrocannula is attached to a 5 ml syringe of BSS plus or any fluid you want, is inserted behind the nucleus under direct visualization and through sideways motion. Nucleus is engaged in the sclerocorneal tunnel and counter pressure at the posterior lip leads to its removal. And the curved angulation prevents any tissue trauma, as there are 3 holes for fluid, 1 central trip and 2 holes on both sides. So there is no anterior chamber prolapse and no anterior chamber maintainer is needed. So these are 2 videos. So routine SICS, I prefer mainly temporal or superiotemporal main incision, and using varied type of incisions like the chevron or the radial cut if the nucleus size is large. So after pushing the dye and its removal, because it's an intumescent type of cataract, so we need a very good visualization in such kind of cases, and then very controlled rexes is made. So it was very intumescent, so I prefer the microcapsular forceps, routine entry, and then prolapse of this white mature cataract into the anterior chamber. And now this specially designed hydrocannula goes inside, and there is no need of anterior chamber maintainer. It comes out the very large nucleus and only 6 millimeter with good side pockets and we can put then the PMMA or any foldable IOL or multifocal. So this is again a very large nucleus, you can see in this case. It is prolapsed into the anterior chamber. This cannula goes inside, a little bit pressure at the lip, and it comes out very easily. If it doesn't comes out, then we can give radial cut. So this study has already been published, and I think Dr. Gurnani has already presented. So that is our study. So just recently SICS Spatial Journal in the Indian Journal of Ophthalmology, this study has been published as a randomized control trial. So I won't go into the details. So just the two brief finding, very important finding. First is the change in the endothelial density. So in the OVD group, the visco expression, there was 9.7% loss of the endothelial cell, and whereas in this technique 4.8% only. And also this was a very strange finding. IOP also decreased and it was maintained till 18 months. So in the OVD group, IOP came down to 8.7%, and in the hydroexpression technique it comes down to 7.5%. This is something new that we have come out with our study. Otherwise we have known that the phaco lead to decline in the IOP. So in the conclusion, a recent article reported acute shortage of OVD in the European market and is likely to affect the whole world because of the scarcity of the raw materials. Hence, we have to look for alternative of OVD and also minimize its uses in various steps of surgery. As per our knowledge, this is the first large-scale analysis highlighting the pachymetric, IOP and endothelial cell changes during nucleus removal by two different nucleus removal techniques of M6. So this technique is a simple and repeatable technique of nucleus hydroexpression using a new innovative hydrocannula, and it is under patent. Thank you so very much.
Presentation, Dr. Morya. And congratulations for the innovation for that cannula.
Thank you, sir. Thank you so very much.
One thing I want to know, in case this cannula is attached with
Any 5
Dispovan
ml.
or
Dispovan.
Medicine.
Dispovan.
So in Dispovan, basically, is there a continuous flow? It depends basically when you are doing it manually.
Yeah.
Chances of continuous flow is there, or there is shaky type of?
No, it's a continuous because of the two. There are two other openings are also there. So there is a regular. I could have shown into 3D, or after the patent, we will show the whole technique, how it acts, how the fluid goes out, and it maintains the anterior chamber. There is no shallowness of anterior chamber. This is the.
Cataract, it is easy, but in hard cataract, I think it will be difficult to maintain the anterior chamber because you have larger nucleus and maybe incision size and flow may not be adequate for.
I have shown you the first video. That was a very hard cataract, and the second was a little bit softer but very large, still very large. Yeah.
I am talking about grade 4 and
Yeah,
grade 5.
in that case we need to give a lateral radial cut. There is no harm in that, and applying one suture.
When chamber becomes shallow, then there is chances of basically negative pressure will create.
Yeah,
So that will cause,
definitely.
basically PCR or even dialysis also.
Yeah, definitely.
It is long term. Basically, you have to go for a study. Only 30 days follow up is there.
Yeah, that's already published, but now we have data of 18 months.
And
So,
data of stigmatism also, surgically induced stigmatism in these cases.
yeah, that is also there. That will be published in a separate way.
Okay.
Yeah.
Okay. Thank
Yeah.
you.
The SIA came from 0.58 to 0.92. The surgically induced astigmatism means after using all different incisions, and which the chevron fares better in all those incisions.
Again, it depends on nuclear sources of different grade. In a smaller grade, there will be a smaller incision.
Yeah.
And lesser SIA.
Definitely. The incision size is in direct correlation with the SIA. Definitely it is.
Nice.
Thank you so very much.